Very much. Let's begin.
Thank you, Madam. At this juncture, we are honored to recognize the distinguished panelists joining us today. I invite Dr. Rakesh Segal, Dean, AVMCH, to felicitate our panelists. Mr. Suresh Samuel, full-time member, Board of Management, VMRF, and Chief Strategy Officer, Office of the Chancellor. Dr. Eve Rittenberg, Assistant Professor of Medicine, Harvard Medical School, USA, and Associate Physician, Division of Women's Health, Brigham and Women's Hospital, USA. Thank you, sir. Sir, thank you. Next, I invite Dr. Damodaran K., Medical Superintendent, AVMCH, to felicitate the following panelists. Dr. R. Venkateswaran, Additional Professor of Medicine, JIPMER, Puducherry. Dr. Vimal M., Professor of Pathology, Sri Manakula Vinayaka Medical College and Hospital, Puducherry. Dr. Parthiban Srinivasan, Professor and Director, Center for AI in Medicine, Arupadai Veedu Medical College and Hospital, VMRF. Dr. Vidyavati Satish, Professor and HOD, General Medicine, Arupadai Veedu Medical College and Hospital, VMRF. Thank you, sir. Recognizing the transformative potential of AI in healthcare, Vinayaka Mission's Research Foundation has established the Center for Artificial Intelligence in Medicine at Arupadai Veedu Medical College and Hospital campus. To elaborate on this initiative, I now invite Dr. Parthiban Srinivasan, Director, Center for AI in Medicine, to share more.
Are we having it here? Good evening, ladies and gentlemen. It's truly an honor to stand before you today with the esteemed presence of our board member Sam and our chief guest Dr. Eve Rittenberg and the eminent faculty members from various hospitals and medical schools, our colleagues and friends. Today it's a great pleasure and I'm so thrilled and happy to introduce Center for Artificial Intelligence. We proudly call it as CAIM. Center for Artificial Intelligence in Medicine. So let's have a round of applause. Thank you so much. Vinayaka Missions Research Foundation, Arupadai Veedu Medical College and Hospital. And let me tell you this. A big breakthrough can happen when what is suddenly possible meets what is desperately needed. What is suddenly possible is artificial intelligence. Suddenly everybody is talking about it. AI is the new electricity, and AI is pervasive, and we have already seen the demonstrated capability and success stories of AI everywhere. But let's look at the other end of the spectrum, which is what is desperately needed, the healthcare industry. Worldwide, the medical system is overloaded. Last 10 years, the number of patients have doubled. And even the developed countries talking about the doctors burnout about 80%. In India, it is much more. So, what is the cure? Is AI the cure for doctors' burnout? The answer seems to be yes. The artificial intelligence can record our doctor's notes. It can make sense of our medical histories and read more deep into the medical literature than any human ever could. So, given all this, with this background at Arupadai Veedu Medical College, we have created the Center for Artificial Intelligence in Medicine, and the Center for Artificial Intelligence that we have developed this year, and we are probably one of the earliest birds in India to set up this Center for Artificial Intelligence in Medicine. And world over, in the last 1 year, if you take any subspecialties in medicine, oncology or cardiology, and any of these disciplines, if you take the top 3 hospitals within these subdisciplines, like if you take oncology, MD Anderson Cancer Center or Sloan Kettering Cancer Institute or Mayo Clinic, and in this case, the cardiology, Mayo Clinic and Cleveland Clinic and Johns Hopkins and all that, everybody in the last 1 year, they have created this center. In Singapore, a couple of months ago, they created the Center for AI in Medicine. And in India, as I said, let me repeat, we are probably the first one to create the center. And also, we are starting a course on this. And let me tell you the 3 objectives of the center. The 3 objectives of the center. The first one is the educating the future doctors. And in fact, as a matter of fact, I was talking to one of the senior doctor about the technology AI, and he immediately said, as long as if it is a medicine, I would love to expand my knowledge domain. But then, when it comes to technology, it will be a bit difficult for me to unlearn and relearn new things. And it's probably the current AI along with the healthcare. So that's the current trend. So realizing this factor, and our management has taken this decision to be more proactive and setting up this center for artificial intelligence. And as a part of this, our first objective was the education for our future doctors. And a couple of months ago, with Dean and everybody, all of them who are here, so we have successfully designed our own course, and we have created our own syllabus, and then as a part of the microcredit 2-credit system. And this course covers 3 major things. The number 1, foundations of AI in healthcare. Number 2, AI tools and techniques for the medical doctors. Number 3, the real-world applications. So with this, currently, we have already started. Probably we are the first one to start this course in India in the medical school. Then the second objective is collaborating across the departments. So when we have the AI in place, when we look at every department they create data, either in the form of numbers, either in the form of images or the textual information. So AI is good for pattern recognition. Interestingly, all the healthcare sub-disciplines has some amount of hidden patterns, and AI has the potential to uncover those patterns in terms of interpreting the numbers, or even finding out some of the not so easily comprehensible patterns, or even generating the text, understanding the text, reading the documents. So all that stuff, we are trying to talk to every single department in our AVMC, like starting from anatomy, biochemistry, biotechnology, drug discovery, microbiology. So we are in the discussions with every department and trying to understand the possibility of integrating AI with every individual department's ongoing research activities. And we are hoping that this will result in possible potential grants applications and winning some of these awards. Third one is driving innovation, and we all know that soon we will be having a super specialty hospital, and we will be having potentially possibility of having robotic surgery and telemedicine, digital health, and so on and so forth. So AI, applying artificial intelligence algorithms applied to wearable sensors, genomic information, blood works, scans, and all possible medical data, they can create customized, tailored treatment plans. So this is what will drive the innovation, and it is our innovation. It need not have to confine to our own campus for the benefit of the human society. So that is the objective, third objective. So with these three objectives in mind, at the start of our, in the beginning of this journey, these are the three objectives. And to substantiate this, for instance, we all know that traditionally the patient and the doctors, the relationship, which is hierarchy, the patient's data is only known to the doctors, whether it's the data, information, all the knowledge. And the ivory tower of this medicine is getting shattered now with the arrival of the digital health. So now the relationship is more at the same level. For the first time, the patients are becoming part of the ecosystem in the healthcare. So the patients do have equally accessible to the data with the arrival of digital health. Now another trend which is imminent, that is the third element, the artificial intelligence, doctors, and their patients, all the three members in this ecosystem which is emerging. So given this kind of a trend that we are witnessing, it is the right time that we should embrace the AI into every possible aspects to bring more efficiency in our operations as well. So with that, with the blessings, as well as with your support and encouragement, I'm sure that quickly we will move into the next level in the CAIM. Thank you very much.
Thank you, Dr. Parthiban, for that introduction on CAIM and its objectives. We now proceed to the main highlight of this evening, the panel discussion on AI in medicine, moderated by Mr. Suresh Samuel, full-time member, Board of Management, VMRF, and Chief Strategy Officer, Office of the Chancellor. I invite the moderator and our esteemed panelists to the dais. So please, you may take the dais. Dr. E. Rittenberg, Assistant Professor of Medicine, Harvard Medical School, USA, and Associate Physician, Division of Women's Health, Brigham and Women's Hospital, USA. Dr. R. Venkateshwaran, Additional Professor of Medicine, JIPMER, Puducherry. Dr. Vimal M., Professor of Pathology, Sri Manakula Vinayaka Medical College and Hospital, Puducherry. Dr. Parthiban Srinivasan, Professor and Director, Center for AI in Medicine, Arupade Veedu Medical College and Hospital, VMRF. Dr. Vidyavati Satish, Professor and HOD, General Medicine, Arupade Veedu Medical College and Hospital, VMRF.
We'll get it started, and right, Professor A.K. Das can join us. So good evening, all of you. It's a great evening to have eminent panelists to discuss on artificial intelligence in medicine. On behalf of Vinayaka Missions Research Foundation, we welcome you all for this panel discussion. I think this evening is going to be quite an enriching discussion on the technology, the mind, and also with regard to the humanity. Said that, given the prelude on artificial intelligence in medicine, I just want to touch upon few important areas which I think will be helpful in terms of setting this context. And I have a very difficult job with all the academicians. I am trying to moderate it. I don't. So I will try to do the best, whatever I can. And to start with, I mean, we all know that artificial intelligence is very pervasive and it is transforming medicine and enhancing the healthcare delivery and improving on the patient outcome. In fact, the last few weeks before, I was traveling in the United States and happened to spend a few days in Boston, wherein I came across a lecture by a distinguished professor for medicine in Harvard Medical School by name Richard Steinstein. He was actually putting together a framework for artificial intelligence in medical education. In fact, that is something that I came across, wherein he was talking about how he is developing complete modules specifically from a MCQ standpoint and also with regard to the different case studies. And all these things are coming well together. In fact, he was talking about few use case examples. And as you know, nowadays, a computer with the retinal images can determine the sex. To that extent, the data and machine learning has come together to predict all through the artificial intelligence technology. Said that, so when you look in terms of the use cases, what I came across in during this discussion in Harvard, the first one was with regard to this diagnostic imaging, where specifically they were talking about the convolutional neural network and also a recurrent neural network. That is what they are specifically highlighting when it talks about a diagnostic imaging. The second was more to do with the drug discovery, the drug development and drug discovery. The third was on clinical decision support. The fourth was on personalized medicine. The fifth also was with regard to public health and epidemiology in terms of predicting transmission patterns. The next one was on clinical trials, specifically on drug development. And another interesting area they were talking about was with mental health analysis, how personalized intervention can be done. And the last one I came across was genomic analysis, which was more to do with the disease risk and also in terms of personalized medicine. The reason I listed all this thing was, these are all very eye-opener for all of us in terms of the extent of work which is going across in all these areas. I also had an opportunity to visit Medtronic and came across a lecture with Harvard Business School where specifically they were talking about endoluminal surgery. So the transformation of how robotic surgery with minimally invasive is now getting transformed into a endoluminal surgery, endoluminal robotics. So how the metamorphosis of open surgery, then into a laparoscopic surgery, which was minimally invasive, and then in terms of robotic surgery, which was minimally invasive as well. And today it is endoluminal robotics, wherein without any incision in the body, how they would be in a position to navigate across the different organs of the body, and they are able to do without any incision or surgery. I think Medtronic and Harvard working together on this initiative, by and large, they have a good cover with regard to most of the organs. The only organ where they said there are some complications, still they want to really unfold certain thing, was with regard to the neurosurgery. But otherwise, rest of the organs, they already have got a complete cover. And artificial intelligence plays an important role in terms of how this robotic surgery will be in a position to really have this effective outcomes. Said that, given this panel, across the listed areas, what I have identified as some of the use cases, I think it's going to be interesting to have a discussion today. And with this eminent panelist, having a specialization on these different areas. So let me start with Dr. Eve Rittenberg. I jotted down a couple of questions, specifically you from the trauma-informed care, where you think that we could emphasize with regard to AI tool design while it comes for trauma histories. That could be one question, Dr. Eve. And the second one is, I also want you to share a few thoughts with regard to artificial intelligence contributing on women health beyond reproductive care, because you are also an associate physician with Brihan's Women's Hospital, one of the biggest hospital in United States. So maybe your insights in terms of beyond reproductive care, anything to do with the chronic disease management or mental health and trauma recovery would be a good start for this panel discussion.
Well, thank you. Can you hear me? No.
Yeah.
Yes? Can people hear me? Yep. Okay. So thank you so much, Mr. Samuel. And I would like to thank the entire, no. The volume, is that better? Really close? Okay. So thank you so much. I'm really honored to be part of this panel. And I have a lot of thoughts on the topic. I'm going to start just sort of with my general overview for where I think particularly promising areas for AI in medicine open, and I can think about that in particular for women's health, and then I'll talk a little bit about an exciting project that I'm part of. So, as you were kind of laying out the framework for where AI holds so much promise, I think that I really see it in two areas. So one is in these places where AI can just do better than we can do as humans. So taking the huge amount of data and helping with clinical decision making. So both in terms of making diagnostics better. We know that diagnostic error is a huge problem in medicine. I think the latest study was, 5% of outpatient visits have a diagnostic error, and so clearly AI can do better than us. We've seen that there was a study published this week showing that AI did better than human doctors in coming up with the correct diagnosis when presented with cases. And then also in supporting chronic disease management. So, when I think about in women's health, for example, in cardiovascular disease management. So we think about managing the traditional risk factors, including, cholesterol, hypertension, diabetes. We often don't think so much about the other parts of women's medical history. So, for example, pregnancy complications or premature menopause or the other hormonal and social factors that it turns out have huge impacts on women's cardiovascular disease risk. And that's often because we don't have access to that data. When we're seeing a woman in clinic, we don't think to ask, or we don't know about those other pieces of her history. But an AI tool, will gather all of the relevant information and can help us make better predictions for risk. So I think in particular that's an area that there's a lot of promise for AI. And then the second piece, when you showed that diagram of the transformation in the patient-doctor relationship. So, again, this is an area that I think a lot about, and I actually think that as we've suffered the sort of unintended consequences of some of the other technological breakthroughs, in the U.S., the electronic medical record has sort of grown out of control to take over a huge part of the time and energy and what doctors spend their time on. We spend our time at a computer rather than looking to a patient. And I think AI, by offloading a lot of that administrative burden, so taking away the charting, the coding, the billing, sort of all of that piece can actually help restore the patient-doctor relationship to one that's better, both for patients and for doctors. And when I think about trauma-informed care, it's really about creating a healing environment, a healing relationship, and that has gotten, I think, that is in danger right now, at least in the US, and you said here as well, that's taken away. And so this potentially, it's sort of counterintuitive that a technological breakthrough can actually help strengthen the human component of medicine, but that's where I see there's promise. And so of course I will say that I have two fears as well, that with any breakthrough there's also risk. And so I think the risk in terms of the diagnostic and management piece is that A is not perfect yet, and it hallucinates and makes errors and has bias. And so how can we, as we're designing these systems, make them high quality enough that doctors can actually rely on them and not be in the position of having to supervise every single decision that AI makes. And so I think that's one risk. And then in the other area, in that sort of patient-doctor relationship, I think the risk is that instead of offloading and taking away pieces of work, that just like the electronic health record did, it unintentionally somehow adds to the workload. So I think there's both promise and risk in both of those areas.
Yeah, thanks, Dr. Eva. I think you brought in some very important points. Definitely this EHR, what I see there in US, it really has created a burnout for the doctors, right? The amount of time they spend in terms of documenting in the EMR and the electronic health record. That said, I think the other point when it comes to with regard to the chronic care, I think from a technology perspective, there are a few focus elements which attributes to the artificial intelligence. One is the machine learning. The second is more to do with the NLP, the natural language processing. And the third is with regard to the deep learning and predictive analysis. So all these things, I think when it is coming together, I think that will really help in terms of bringing a better care quality on this chronic disease management. And with regard to trauma management, I think this predictive analysis is going to make a big impact because the way that machine learning is getting all the data together, curating the data and make it something very specific, I think there would be a much more optimized trauma care in the days to come through all these things. That's what I suppose. So thanks for that initial thoughts. I would like to turn it on to Dr. Vimal, specifically on the pathology side. So pathology is in the forefront of artificial intelligence, and I think this is a big progression that has happened specifically with regard to artificial intelligence in the diagnostics. And in fact, if you look in terms of the computer vision they call in United States, where it is more focused with regard to the quality of the imaging and the diagnosis that can happen. So my question to you, Dr. Vimal, for the point of discussion would be, how AI can improve in the diagnostic accuracy, and how do you see this trying to impact?
Good evening, everyone. Thanks for the question, sir. As you know, like pathology is mainly a diagnostic field, and the main challenge in the pathologist is the turnaround time. So labs, when they are faced with so many workloads, actually will be more concerning about the turnaround time. The role of AI is mainly in decreasing the turnaround time. Actually, the algorithms we can classify it as a diagnostic algorithm or a screening algorithm. So screening algorithm, like it will help the pathologist, like which areas, when we are overloaded with hundreds of slides, which area to be focused and which area has to be concentrated. So those kind of things, this AI will help you. So another thing is actually it's more of like where the objective grading, the grading of the tumors, where we have to calculate the number of tumor cells, the proliferative activity of a malignancy. So those things actually AI can help. Thereby it will be reducing the inter-observer variability, and thus it will be aiding in the things. So definitely it will be decreasing the turnaround time, as well as it will be improving the diagnostic thing. But the other challenge is actually one more thing. It will be also when we will be faced with difficulties in getting the data from medicine department and the radiology report. So AI can have an algorithm of integrating all this interdepartmental things so that a pathologist can have an overall view. So the challenges, it can be a data data set can be, it will interpret with the data set available. Sometimes pathologists, when they are encountering a very rare case, so it can retrieve those rare cases, so it will be reducing the turnaround time in that way. But the other aspect of this is it needs a lot of data set which has to be validated, and this validated data set has to be like a universal biological variations, and everything has to be inter-region variability. So all these things has to be taken into account. So mere AI alone cannot help in, but a pathologist supplementation actually is needed for this.
Absolutely. I think a very interesting point. In fact, one takeaway from one of this session, what I attended in Boston, is AI is going to create a big knowledge base. Okay, it's more than artificial intelligence, is more of an augmented intelligence, particularly for our doctors. And with this available of a large database, knowledge database, I think the doctors will bring in the right intelligence to pick and choose what they want with regard to their focus area. And also with regard to you made a point on this rare diseases or rare findings. I think that is another area which is going to have a lot of focus, because there are so many diseases, rare diseases. I think it counts in terms of few thousands of rare diseases, wherein we don't have a proper, alignment of drug specifically on the molecule at a protein level to address these things. I think this is another important area pathologically what they are working on, to see how they can bring in some newer drug development, because now drug development is going to be on a faster pace. So how they can create some newer drug development for some of the rare diseases. So thanks for that initial thoughts.
And also actually, as you said, that robotic surgeries, pathologists actually, we will be glossing the specimens. Now that's Muse microscopy, all these things, without even glossing the specimens, the three-dimensionally actually itself the diagnostic thing can be interpreted, so that at any point of time we can go back and have that three-dimensional integrity can be present.
Absolutely, absolutely. Yeah, this endoluminal robotic is going to be very interesting. And in fact, there is an experience in terms of how you can see that. They are also creating some simulations around it to see how, because without any insertion, it is going to have do all those things, right?
Yes.
So they are taking through an experiential learning as well in terms of how to really go about on that. I also have one more follow-on question, because since the pathology is your area of focus, what are the ethical frameworks that you think that we need to come up with? Because this is going to be a bit disruptive, the way that artificial intelligence is thought through. Yes. Okay, so particularly from a diagnostic side, what do you think some ethical frameworks that we need to think about?
Actually, the patient consent plays a major role here, I wish. So it's actually, though we are saying that AI is improving our diagnostic things, decreasing the turnaround time, all these things, actually patient should be informed that this kind of things is being reported on this thing, and the transparency. And another challenge in this area is this black box phenomenon, like where the algorithmic approach will not be that much transparent. So repeated validation should be there. So it's mere interpretation of just a report alone by AI will not be given that self-reporting freedom. So it has to be always in a balance with the pathologist knowledge, and the patient should be having the consent of this thing. So it should not replace the entire thing. That is it.
I think that is an important point, and I think while one side we see the progression and development on artificial intelligence, I think enough focus should also be with regard to the other ethical, and with regard to the data security, and with regard to the data privacy. And now, as the artificial intelligence is going to, increase, it's like the data is becoming like a dust. It's called a digital dust or a data dust. I think the more and more cloud enablement is happening.
Yes, sir.
So there is another set of risk that comes from the cloud enablement, and how we really need to have a cloud governance to ensure that the patient health information, or with regard to the generation of synthetic data, can be well managed and well managed effectively. So
And anonymization of this data that is needed.
data obfuscation is very, very important.
Yes.
So I'll turn it on to Professor Parthiban. He comes with a lot of AI experience, and he was running the Center for AI in Ayushar Bhopal, and he has joined Vinayaka Missions as a director for Center for Artificial Intelligence in Medicine. And so, Parthiban, given your experience working in NASA and also running your own company and also working with academics, with IASC and also with Ayushar, and also your ongoing lectures internationally on all this newer history, the drug design and AI, how do you leverage cross-disciplinary insights to drive innovation in healthcare AI?
Okay. Oh, that's a very huge question for me. So it has a very multi-dimensionality in what you mentioned. So from a healthcare point of view, one dimension is integrating with the AI. You have a different levels, like a self-driving cars. So the cars which have a different levels, level 1, 2, 3, 4, 5. Likewise in AI with the healthcare, there are 5 levels. The human only, there are no AI. Then shadow mode, like in the labs, the doctors who give the instructions, students take the notes. Likewise, you do the curation, the terms that you were using. It's kind of AI could be used just for the curation purpose. Then it's AI as an assistant. It's not necessarily that we need to depend on what the AI is informing us. So just take that as an assistant. Then the kind of a partial automation, then the full automation. Even if you look at from an AVMC point of view, every lab has some amount of data. Here another dimension is that the data comes in multiple different formats, like say text. You were talking about CNN, RNN. So like a vision. So like a humans, we do see things, we write and understand letters, and then there are numbers and so on. So from predictive analytics to natural language processing to computer vision, the pathology which will be more to do with the computer vision, whereas the hospital management to be more to do with the recurrent neural network that you are talking about. And then the RNN within such a short span of time is outdated, by the way, the transformer which has taken over the RNN. So all these, so many things which are there, and the options are more. And the good thing is they are all easily accessible. The good thing is, compared to 5 years ago, the data was not easily accessible. Today, you have open source data, you have open source algorithms, and then the social media, which is helping us to, if we have any questions, clarifications, doubts, people who are updating on a regular basis, you just need to follow them. So with all that, how do we leverage all this, which is available at a click of a button, to enable the ongoing research in every one of their own labs, hospitals, and facilities. So that's one part of it. And then you shifted me towards the computational chemistry, drug design, and so on. So that is again going in the another one of the dimension, like starting from the classical mechanics to quantum mechanics to now this is the quantum computing which is getting into place. Because when we talk about data, I normally say this, 2 types of big data. One is the financial sectors. They have a very minimal features, but then billions of credit card holders. Whereas in healthcare, we have if we open the Excel sheet, we do not have too many rows, but then the columns are too many. The feature engineering is taking us very complicated. So this is where the features like quantum computing, which is showing a lot of promise in the very near future to play a role in this. Then the other aspect is the knowledge graph. So if we look at it, the 3 aspects in the healthcare is disease, then you have proteins, biology, then the drug, which is a chemistry component, the triangle. In the disease part, there's so many other branches will be there, and then in the proteins you have other branches like metabolites and so on, and the drugs, the other side effects and so on and so forth. There are too many parameters. How do I connect this? Can this AI read all of them, connect the dots, make sense out of it? This is where can I infer something, a target identification. We still do not know for some of the diseases why we are getting the disease, what is it causing. We are sometimes wrongly targeting the targets. So why one of the reasons 95% of the clinical trials are failing, because the fundamental biology could be wrong. The targets which we are thinking, this is what causing the disease, probably not necessarily true. How do I make sense out of it? This is the other aspects of AI. I think probably I will come back again in the next circle. So maybe you can ask the same question again. Maybe I can continue the conversation.
Sure. I think, yeah. The reason I put it a loaded question was, given your experience and you are going to run this Center for Artificial Intelligence in Medicine, that's the reason I really want you to swing from computational chemistry to drug discovery and also on the other AI components.
I'd like to recognize the presence of Dr. Ashok Kumar Das, so please join us on stage. Professor of Eminence and Director Academic, Mahatma Gandhi Medical College and Research Institute, Puducherry.
Welcome, sir.
Welcome, sir. Okay. So, I will turn it on to Dr. Venkateshwaran. So you are working with JIPMA in medicine, and specifically my question would be your views in government institutions like JIPMA. What is that you all are doing specifically in adopting artificial intelligence in the clinical areas, and what are the challenges that you foresee? Because all technology adoption is going to be a challenge. While we all come from more of a private setup, whereas in JIPMA you have a more than the required patient load. So what are the challenges that you foresee in terms of AI adoption?
Thank you. So thank you for the opportunity and honor to be a part of this panel. So there are two components to your question. So what is the perspective government setups has towards the AI and the challenges foreseen? So as a clinician, from the background of internal medicine and more of critical care, I can say that one of the important challenges we face is capturing data. So in abroad, there is an automated way of capturing data. Most of them are digitized, and EHR health records are digitized. So in India, there is a transformation into health records that are getting digitized. So we have the hospital information system for more than 10-20 years. But when it comes to AI, they need the vitals. They need the pulse rate. They need blood pressure, what happens to blood pressure from every 15 minutes. Though we do this monitoring in the ICU, but they are not captured. They are not stored. So the hospital information system contains the patient information, it contains the laboratory reports, say what happens to potassium on a daily basis, and it also has the images from X-ray and CT and MRI. But when it comes to AI and the applications of AI, one common situation is diagnostics, say early recognition of patient worsening or developing sepsis or septic shock. So when it comes to these utility applications of AI, we need data beyond laboratory reports and imaging. And the amount of data, as he mentioned, the big data, so the amount of data that is required to train an AI is enormous. We calculate sample size for our research, but when it comes to data with regard to AI is huge data. So one of the important challenge I see is the data that is available to train AI. So though there is an AI algorithm, it has to learn from data. So the amount of data that is readily available at the molecular level, to a granular level, is lacking in many setups. So even if the AI is trained elsewhere in a different patient population, when we use the same algorithm in a different setup, we need to again learn and unlearn. So we call the weights in a network. So this weight has to be altered, and this requires again a huge data. So one of the important challenge I see is how are we going to train these AI to give region-specific or population-specific clues to the clinicians? So they're not going to replace clinicians like self-driving cars, but though there is the final decision is going to be by the clinician, but the clinicians need to depend on this clinician decision support system like AI are going to give inputs, but these inputs depend on the training data set that's going to be used, and this training data sets require huge data. And in government setup, I see the transition going into a digital framework of EHR, but how much of data do we have? Are we having minute-to-minute data? So that is one important challenge. And when it comes to government's perspective, AI is welcome, and AI is I think is going to be an essential part of our life in future, and so there will be a welcome. We welcome AI, but the initial problem will be the cost of implementation. So who is going to pay for this AI? Because when we balance about the cost and what are we getting in return, so if cost will be one major hindrance, and next comes the regulatory ethical framework and the resistance to change from clinician sides, and all these perspectives comes. And so government perspective, I would say that there is a welcome change, AI, and this will be applicable with regard to diagnostics, I would say. As an internist, we come across patients without a diagnosis. In all of the specialties, we'll have a well-defined diagnosis, whereas in internist, we come across patients who has weakness and we don't know what's the cause of weakness. So we have we have a set of diseases. We make a syndromic diagnosis, but we don't know what is the etiology. And there are diseases yet to be, for example, in NEJM, we had this Vexus syndrome. It's recently described. So it has never been described earlier. So breakthroughs and newer diseases are being defined for the first time. And then the artificial intelligence has played a role in making this diagnosis. So more and more unknown diseases, as one of the military generals in US is an unknown. So we are not even aware of certain diseases that are very specific to our regions, and AI is going to see the pattern. And he was rightly mentioning the pattern. As what comes to my mind is we have a wonderful, tremendous part of a brain, occipital lobe, for recognizing pattern, and that's confined only to vision. And when it comes to data and pattern recognition data, we always transform the data into visual form. We call visualizing data. So we depend on our pattern recognition ability of our vision to make out patterns. But AI has that ability to find patterns in any form of data, need not be visual. So what I see is, with enormous data, new disorders will be clusters will be identified, and new disorders will be discovered, and that is one area. The other area is optimization of doses, because not only renal modification and hepatic modification, we have to look into genomics, as you said, personalized medicine, and these. So this AI can definitely help. And third, in radiology, the imaging, the amount of deep learning it can do is quite extensive. So I think there is a welcome change, and cost will be the only hindrance, and there will be maybe initial resistance to change. Thank you.
Yeah, we have covered a lot of good points, actually, Dr. Venkateshwaran. I think while cost is a factor that need to be looked into, I think the way the technology enablement is happening is trying to bring down the cost, because right now the entire system is going to work on open source technology, and that is where it is. And then while this data storage, if it is moving to cloud, then that brings a different elasticity in terms of managing and maintaining the volume of data. So there could be some cost optimization there too. But another important point what you highlighted is with regard to curation of the data, which is very, very important. So now we have tons of data, how it has to be curated and how it has to be made very specific.
I think it's supervised learning and unsupervised. I mean, okay. Are you referring to supervised learning?
Yes, supervised. Yeah. No. What happens is one side we are having the supervised learning on the curated data. The other side, AI has an ability to develop a lot of synthetic data. Okay. If you try to input or feed a particular pattern and some data algorithms, it also generates a lot of synthetic data. Now that becomes an important in terms of how to differentiate or how to use the synthetic data in addition to the real data, which can be a delta, small component. So those are the things which is going to be another interesting area. And you also touched upon with regard to the very newer diseases,
Yes.
that it is generating based on or identified based on all this data. And I think I'm going to come back to you, Parthiban, on this in terms of the drug discovery, when we go about in terms of identifying new diseases, and what is that and how the AI is going to span across.
I think baricitinib for COVID was recommended by AI. We had we had steroids from trials coming up from Solidarity and the other trials, but recovery trial. But baricitinib was suggested as one of the options for COVID by AI. So yeah.
Sir, Dr. A.K. Das, welcome to this panel, sir. We are honored to have you in the panel, and you are a professor of eminence.
Thank you.
And director academics, very accomplished person in the field of diabetes. So with the extensive experience in diabetes care, how do you see AI transforming on diabetes management, more in terms of predictive analysis or any personalized medical care?
I think, Sureshji, it's a very loaded question, and you have told, we have given the hint. We always talk about AI in diabetes as transformative. It transforms many ways. It transforms many things which were not known before, which can be scalable, which can be made precision medicine, and which can be adaptable. Now, I'll give some example that diabetes is a lifelong disease, and there is at present no cure, even though there may be remission in very rare early case diabetes mellitus. Now, one of our major issues in diabetes mellitus, with a disease which was 102 millions by the estimation we published in the Lancet in June the 7th last year. But the paper which came last week from WHO, it has said the count is 200 millions in India. Now, this count came because they took into consideration two things: only fasting and HbA1c. They did not consider the postprandial, after food blood glucose. The point I'm trying to make is that to handle the data, to derive the diagnostic guidelines is very important issue. And it has to be specific to the region, to the race, to the type of diet we take. So that has not been worked out. So it has been rightly said that AI will have, what are the two things that we always see in diabetes with AI? One is the speed that which it solves the problem, and to the scale into which it can rise. So I'll give an example. We did a study which Venki is my student, my best outgoing student. So I call him by that name.
Most of the people are your students, sir.
So what happens, Sureshji, is that we want to say the diagnostic criteria. Now it started, as we started in the beginning, we said 120 the fasting and 170 or something like that postprandial. Then we wanted to correlate the data of the diabetes with the retinopathy, eye changes. And it came to be organized that it is about 126 fasting and 140 postprandial. Now, this has been done in a small number of cases compared to AI. So, if you keep the data of the blood glucose of the general population, and the other side the data on the retinopathy in the diabetics, we can find good correlation. Number two, it's a dynamic disease. The blood glucose changes from minute to minute, time to time. So what we call CGMS, continuous glucose monitoring system. It is actually available in the country today and very widely used, because 3 days cost only 2,000 rupees, but the company is clever. They're withdrawing gradually the 3-day one and only doing 14-day one, which cost about, not much, about 7,000 to 8,000, 5,000 plus. So now this CGM predicts the way your diabetes is moving. Are you getting my point, sir?
Yes, sir.
And also predicts the way your diet and your treatment is making your blood sugar rise or fall. So this data observed over a length of time, what you rightly said, can give the predictability of the future. whether the diabetes is becoming from bad to worse, or it is becoming better. So that's a great help of the AI. The second one is we have now EHR has become the norm. We all have EHR, and the electronic health records produces large amount of data, and those data to confide in you in many ways goes to waste. So we are trying to utilize the AI. We have just launched a course, sir. I think being across the road, you mentioned that about the AI in the healthcare. So it is an advanced diploma program. So one of the things that we thought in the beginning that we will do is to feed the data of the diabetic patients from the EHR of about 20,000 patients and see the pattern. So I view it as the one which can give you a lot of research inputs and predictive values and lot of outcome values, lot of ways, the markers for the eye complications, kidney complications, heart complications, but that cannot be done manually. AI and machine learning can do it. Third thing is that we always nowadays use handheld cameras which are non-mydriatic. We don't have to dilate the people. One can drive back home immediately after the eye testing in diabetes. Now those data are sent immediately to a program which is called optometry in diabetes. And the moment we take the photograph with the handheld non-mydriatic camera, the photo goes to the AI store and we get the report. And that does not make the ophthalmologist jobless, but it makes our life easier. I don't have to go for an ophthalmologist to tell me whether retinopathy is there or not. I can immediately get a report on this. So the same thing like radiology, sir. There are a lot of images. They say lakhs and lakhs of eye images are stored in AI. So the moment I take the photograph of Mr. X, it is compared to those and it gets the data. So the diagnosis in the diabetes has become much easier because retinopathy is the marker of nephropathy, also marker of many other diseases in the diabetes. So that is diagnostic. Last and final, sir, lifestyle is to one very specific. My lifestyle may not suit to others. So if you say to prevent diabetes, you have to have a lifestyle modification. We give a lot of modifications, sir, but people do not adhere to it. Now the lifestyle which is depicted or driven by AI is the one people really adhere to. I'll just give an example. AI has discovered, I'm not against Italy, sir. Taking 4 Idlis in the morning gives a great surge of blood glucose. And AI also has taught if somebody has a high surge of blood glucose following Idli breakfast, you can divide the morning dose into 2. And we get the hint from the AI how much the same morning dose of say 30 units of insulin, we can divide into 2 split, called split breakfast and split insulin. It has also showed in Indian diabetics what type of food produces swings in the blood glucose. Now, if somebody having always high blood glucose, say somebody having 170 24/7, and somebody having a blood glucose of 160 and 100 and swinging very rapidly, the second one is a worse candidate. He will get into more complications. So it's like the thing that a clock which has stopped is better than a clock which is 5 minutes late, because it's always 5 minutes late timing in that scenario. So, but in the diabetic, the swings, the rapid fall, rapid rise are the ones which produces more complications. Am I correct with that, madam? So we get that answer from the monitoring. So AI has played a great role, number one, in the diagnosis, in giving normative data for a population which was not available earlier. It has given the data to provide the pattern of blood glucose in a particular individual. We don't get it by doing multiple blood glucose. It gives the pattern. It gives what we call time in range, how much time my blood sugar in range, that is between 70 to, say, whatever you fix. For the pregnant ladies, will fix between 70 and 140, and we say about 80% must be in range. For ordinary people roaming around and all that, we fix that data, which is about, say, 70% in range. How much time it is above the range, and TAR, TIR, TAR, time above the range, time below the range. And from there, it also depicts that what is going to happen. The pattern of blood glucose also depicts the trouble that man is going for. I'll give an example, last example. There is somebody which has got a neuropathy, nerve disease in the leg, which is very common in across the globe. It can give you very, very minutely that we have got socks, and the socks are fitted below the shoe, and the socks is connected to AI, and it records the temperature of the feet, the plantar feet, and gives a would-be ulcerating area, which can be taken care of. And you know, the leg amputations are second to the road accidents in our country. So finally, to sum up, sir, it plays a role in diagnosis. We are using now definitely in the retinopathy diagnosis. We are using it for the recognizing pattern, for propensity to complications. It plays a role in giving the analyzing the data, huge data in diabetes, multiple parameters lifelong, into giving us the insight into the disease and churning out. We have a dictum, sir, same thing you also have, sir, publish. We don't say perish, publish and prosper. If Prem is here, Prem has to publish and become the professor tomorrow morning. He has to publish data already available. So this is a great occasion for the AI to be applied to the number of publications. And publication not only for publication's sake, publication for the career and publication for giving new data to the society. It plays a role in the prevention, plays a role in the monitoring and giving directive. And you know, the insulin doses, when one is insulin pump, is calculated by the AI. Supposing it senses blood glucose and says that you need only 2 units. If some blood sugar is going down, it gives a next dose will be less than 1 unit. So it is a type of dose adjustment for the insulin pumps is also done by AI. And apart from that, AI is heavily used for teaching diabetes because there is a huge disease. We don't have teachers, so we can teach, AI can answer. And sir, our boys, PGs, use ChatGPT for their presentations. And you know, it is beautiful. If you give the words correctly, just introduction will give you 20 slides. If you have a presentation, ChatGPT, I can tell you in secret, will give you the entire presentation in less than 30 minutes. So it's a great use in the presentations, in the teaching. If you have a Benki has a class and he has forgotten to prepare the slides, we use it, sir. We use it for the supposing, sir, you have called me to sir, I called some gentleman from Delhi to give the Logani. Logani was director. Remember Logani, director pathology. His son is a dental surgeon, dental college principal. I called him for the convocation address. He gave the convocation address, which was prepared out of ChatGPT. And at the end it said, it's a good oration, but it lacks emotion. Yeah. So, dear friends, ultimately it comes down to human intelligence. It is human intelligence which is the boss of the AI. AI is not our boss. So if we obey that simple principle, it is wonderful. And in diabetes, use is very huge. Thank you very much for the opportunity.
Thank you, sir. Thanks for enlightening across many areas. And particularly, I mean, India is now almost a diabetes capital of the world.
200 million.
Right. That's what, when you said it is
25% of the world
yes. No, said that, sir, you also spoke about this continuous glucose monitoring system, CGMS. In the Western countries, you have a very easily accessible to all the patches which they put, and they try to continuously monitor CGMS. So in India, it's still a cost prohibitive thing.
I must tell you, sir, the CGMS and pumps will be soon available to type 1 diabetes, which are children and who need it.
Okay.
For the type 2 diabetes, because it has been already the draft, I work for the government also, it has been made. But the type 2 diabetes take time. But abroad, it is available for anybody who is on insulin.
Yes. And insurance completely covers, in Americas, completely covers even for this pump and also for the CGMS.
Yes.
And that is something that, I mean, if you can also, if you can produce a low cost
Yeah.
The-
We have given a project to the Indian Institute of Science, Bangalore, and it's almost ready. A low-cost pump is ready. We have also devised, sir, through AI, a non-invasive blood glucose monitor.
Okay.
It's not from the sweat. It is not from the body secretion. It usually senses the capillaries and gives the blood glucose of that. I'm chair of that particular project. It will be available soon.
Oh, that will be a breakthrough, sir,
Yes.
without invasive.
Yeah, it sends
if
the
you're able-
data to the AI, and AI gives us the idea about how much the blood glucose is.
Excellent, sir. Thanks for enlightening us on this. And coming back to Dr. Vidyavati, so I just put some specific questions on the pressing challenges faced in medicine today. Okay, and where you think AI can address it.
Thank you, sir. Pressing challenges in medicine, it's a clinical diagnosis and the more accurate diagnosis. AI it's useful and it's an useful assistance, but it cannot replace a clinician. And in AI, you have a certain set of data for this particular condition. These are the parameters or how we go about to diagnose. But there are some uncommon manifestations of some common diseases that AI might not pick up. So, or when in a single patient there are multiple problems, that also AI, it's difficult to pick up. So in this scenario, AI will assist, and the healing touch ultimately will be the clinician. That I fear that that may go in work in future. That is the only concern about AI. But on the whole, in an ICU setup, in critical care medicine also, the algorithm which AI has designed, it's wonderful, not only in sepsis, also for arrhythmia diagnosis, lot of algorithms which it's really useful to diagnose. And one of the important challenges during the pandemic, and AI has helped us in telemedicine. That was one thing which we have not touched.
Yes.
And telemedicine, even in Puducherry, we have used it. In our institution, we have used it. We had war rooms, and not only for the patients, it's also for the bystanders, where trauma care, resilience, Madam has spoken about. It was very useful during the pandemic.
Yeah. So like what Dr. Sir said, I think Dr. Das Sir, I think the intelligence primarily is with the doctors. Okay, to whatever the data evolution or revolution can happen, I think it comes back to the doctor in terms of the intelligence to use the right information and data to treat the patient. I think that's very important on this. And Parthi, I'll just come back to you on specifically with what Dr. Venkateshwaran spoke about in terms of new diseases.
Yeah.
And how this drug discovery is happening around this space. So maybe you can enlighten us.
Yeah, that's a fantastic question. In fact, when he was talking, a couple of points also was triggering. So I'll come to that later. So when we go into we are shifting from healthcare to drug discovery. In the drug discovery, it's a very long process. Like it takes typically 15 years, and investment goes up to $2.6 billion. And if you look at it, it has a different phases, starting from the disease, which is responsible for the disease, and validating the target, and then finding the small molecule which can go and interact with the target, and then optimizing it, because the drug, when it is entering the human body, how the human body is looking at the drug, and how the drug is looking at the human body. So both the aspects which needs to be addressed at the optimization stage. From there it goes to the preclinical, clinical phase 1, 2, 3, and so on and so forth, even in the marketing. Now, each one of these stages are already supported by huge databases, which are still, we have not leveraged it for a full extent. So each one of them can play a role. And when it comes to AI, so when you look at it, when the drug which progresses from disease to target to hit identification to lead optimization to clinical stage, by then we would have burnt about few $100 million. And if AI is super smart, it will tell you right at the stage 1 itself, hey, you are going wrong. Meaning, your AI need not have to be only look at it from a success point of view. If you fail faster, fail cheaper. So AI enables you to fail faster. So instead of fail at the much later stage, by then you would have burnt about $800 million. So you don't want to have that kind of a situation. So that is one aspect. And so as you rightly said, the humans have certain way of a pattern matching. Like when Lipinski from Pfizer, we was getting into a pharmacy, looking at each one of those drugs. Each one of those drugs are a success story on its own. Because out of millions of compounds, that one specific drug which has came to the store, that's a success story. Which means that each one of them there should be something common. What is that commonality among the drugs? See, whether it's a diabetes or a diarrhea or a headache or a fever, we all take this water. So there must be something common among all of them. So what is that common? So he found that number of hydrogen bond acceptors should be less than 5. Number of hydrogen bond donors should be less than 10. And log p-value, water octanol coefficient, and then molecular weight should be less than 500. Then your water can take care of that. When it goes, it does all the oral bioavailability, all that kind of a stuff. So such kind of a patterns, when you are looking at the rare disease, the problem with the rare disease is it takes about close to 5 years to even diagnose. Hey, I have a good news. You have this rare disease, and you are telling that at the end of 5th year, even in the developed countries, not in India. In India, very many people die without knowing what reason it is. In US, for example, taking example Hashimoto encephalitis, it takes about 5 years for the doctors to diagnose one of the rare disease. If I have the AI, it can maneuver through all the literature in the past for the specific rare disease. And we do have 9,000 rare diseases we have identified. And 9,000 rare diseases, more than 95% of them, we do not have any remedy today. We do not have any cure. So this is where AI come in. Big pharma companies cannot invest $2.6 billion for any of these rare diseases. So meaning because the market is very small, meaning I cannot take the returns. So this is where AI. Now there is a renewed interest in finding a cure for rare diseases with the arrival of AI, because with the AI, I can slash the cost. And whatever it was taking 8 years in the past, now the estimate is 3 years with the arrival of AI. So with so much of potential, there is a huge opportunity for AI to pitch in for the drug discovery, in a nutshell.
Okay, thanks, Padri. You have a comment on that? Yeah.
Just a small comment. In the sense, this year's Nobel Prize, we know that we got for physics, the AI. So that's one thing I wanted to add. To add on that, the other chemistry, Nobel Prize for chemistry, was also given for designing proteins. And designing proteins comes from AI. So there are 2 Nobel Prizes given for AI background, and probably in future, as you said, we had AI already for protein designing. Probably in future, designing small molecules will be the next Nobel Prize winner in future, probably. Yeah.
But this might be a little enlightening. Actually, there is, apart from the paradigm shift which is happening with the AI, there is another paradigm shift which is happening on the medicine, the human side of it. That is, typically why we age, because every day in our human body, proteins are generated, proteins are destroyed. So that's why we are aging. Now, can I make use of this? Can I make use of this natural mechanism? Because drug discovery is at the end of the day lock and key. We are trying to open the lock, but which key? We don't have the key. So when you go to the locksmith shop, he will have hundreds of keys to open one lock. Now, it's not necessary that you have to design a key to unlock it. You can even take a hammer and destroy the lock to open it. That's exactly what is happening now. The concept called PROTAC. If this is the target for which we have been spending last 30 years to find a small molecule which can go and bind to it, we are not able to succeed. Better destroy that using the natural mechanism in our own human body. That's called PROTAC. So this is how AI can design a new molecule which in the concept of PROTAC. So this is probably a Nobel Prize concept.
Okay, thanks, Parthi. I think
Sir.
I have one. Yeah, please go ahead.
Can I have one question, sir? What are the challenges when these AI softwares, when they are coming for the routine practice, the regulatory approval, for the regulatory approval, what things it has to be approved?
Well. Actually, we should divide between the medical devices and the AI that we are using it for drug discovery. At the end of the day, finally, what's coming out is the drug molecule. We don't care whether it was designed by a human or a AI. So there, this question doesn't come arises. Whereas in the medical devices, okay. So actually, this is a huge subject, but then I'll try to minimize it. So this was about in the year 2019. All the U.S. patent offices, they were all talking. This AI guys, AI is at the end of the day mathematics. Mathematics is not patentable. So then, which cannot be regulated as well. So which means that the AI community, they are not bothered about the innovation offices, the patent offices, because they are all going for directly to the market without even filing a patent. Because when I go to the patent office, my AI concept is not fileable, not patentable. Now, actually, because of this AI pressure, all the patent office directors, they join together, all the 5 major patent offices. Now they are refining entire patent law because of with the arrival of AI. If they are not going to change it, the AI is anyway they are going to move forward. Likewise, there will be a lot of amendments. We can expect it in the regulations as well, especially with respect to medical devices.
See, I think there is going to be a very big framework on AI governance across different components, be it at a technology level or with regard to the application level. I think in fact in US and UK we see a lot of work which is going on, including China as well. I think those are things that would also bring a better confidence on the usage of data. And even in Indian government, I think there is an initiative, Share should be knowing about it, has already been started with regard to data governance, and Data Protection Council of India is having one very specific strategic initiative on trying to see how this could be really well thought through at a localized level and also as an international level. See, nowadays the demarcation gets broken up, right? What data we'll have tomorrow, it can be easily available anywhere. So they are talking more on the internationalization and the localization of the data protection and privacy. Sir, I have one question, because I cannot resist this question because you touched upon many subjects. See, when you think we will have a personalized medicine for diabetes in India?
Sir, if you ask me simply, today the medicine we are giving is personalized.
Okay.
Venki will give metformin to an obese person, and he will give a sulfonylurea to a person who is lean and thin and has a blood glucose value high. Now, if you want to really give the precision medicine in diabetes, it is going to be decided by your genome and by your body makeup. And I think that type of precision medicine that you are asking today,
yes,
it will not take long, because today there are I just give an example, sir. We have a disease called neonatal diabetes. This occurs with the first 6 months of diagnosis. Sugars are sky high, and the people give tons and tons of insulin, and it is not that doesn't come down, blood doesn't come down. You know, it comes down by tablet of sulfonylurea. It can be permanent or it can be transient. But this discovery changes the destiny of the neonate for the entire life. Now, this can be diagnosed only by precision medicine and only by finding out KNC11, which is fed to the AI machine. This is a machine learning. So what happens if a child has got diabetes in the first year? It is mandatory, I'm repeating again, sir, it is mandatory to do the blood glucose in the first 6 months, because this will change the trajectory of the whole disease in the future. And that is fed in the machine, and ICMR has taken advantage of that, and we have a center in Chennai where we have kept this, and we just put that drop of blood to find out whether it is type 1 diabetes where you need insulin, or it is a neonatal diabetes, KC and J11, where you need only tablets, and that changes entirely. But this has to be worked out in all varieties of diabetes. We have said diabetes is not a homogeneous disease; it's a heterogeneous disease. There is diabetes called MODI, maturity onset diabetes in the young. We have got LADA, latent autoimmune diabetes, which are talked about Hashimoto encephalitis. LADA. We have got LADI, that is latent diabetes, autoimmune diabetes in the young. So we have lot of abbreviations. For all this disease, we have to find out the precision medicine. Majority of the things are moving towards that, because there are some MODI, which Venki will agree, Midyavati Madam, she will agree, which will not have any complications. They are relatively milder diabetes. So that's one use. The AI can give us the trend which diabetes is going to become complicated. To be little bit sweet is better. But what is sour is the sour companies of diabetes. If you can find out who is going to have the complications, we can concentrate on that and give them the good blood glucose control, good blood pressure control, good lipid control, good vascular control, infection control, and all controls. These life will be longer. And so that is only can be given by AI. So precision medicine and the prevent complications is by AI.
Excellent, sir. Thanks for enlightening us. And
tell you, sir,
yes.
we have just got a consultant to put AI in the administration, sir.
Okay.
Because, sir, we always believe that if management chairman wants, he can sanction that money. So what we have done, sir, the student enrollment, examination pattern, faculty work, that they all complain, sir. Venki will not complain to me. They complain that he is not. So faculty work and to certain extent the basic evaluation of the answers are done by AI. So we are moving towards that, sir. So
sir, in fact, before you joined, I spoke about it, sir. Yes. I came across one of the distinguished professor in Harvard School of Medicine. Yes. His name was Dr. Richard Steinstein. He spoke about artificial intelligence in medical education. And right from MCQ onwards, yes, how the entire academic administration, evaluation, everything is happening. It is a wonderful discussion.
And there will be no NEET leak, because it is all coded. So NEET will be NEET, and Dharmendra Pradhan will sleep in peace.
Yes, sir. Thanks, sir. Dr. Eve, any reactions, comments? What you heard from your perspective?
I think it's so exciting to think about the innovation that is happening sort of across all levels of both of medical education, of practice, of innovation and drug development. So I think that there is so much opportunity. I was just saying one of the projects I'm involved in is leveraging the ability of AI to gather data from radiologic studies and combine it with both coded and free text information from across the medical records, and use it as a predictive of risk for intimate partner violence and for increasing levels of injury. And I think, what stood out to me here is the point that you made about the necessity to train AI in the local context as well. So what may work predictively in one place, so what may work in my population may not at all be relevant here. And so there's all of the work to do to get that information into a format that AI can be trained on and then use. But the possibilities are so exciing. So I think that's what I'll end on. There's promise. There's so much work to be done, and I think it really does have the potential to improve care in many ways.
Yeah, thanks, Dr. Eve. I think I'll open this for Q&A sessions from the participants. Any questions? Yeah.
Very excellent discussion we had, and I congratulate the management as well as the panelists for this. I really enjoyed this panel discussion, but I have one or two queries. So one is for Dr. Eve, that how do we control AI? I mean, it's the ethical part and other things. How do we have some framework for that, or we are just struggling to do that? So that one is that. Second question is for the pathologist, that supposing you are having you want to diagnose something using AI, what is the diagnostic accuracy? Say if you are seeing from cancer slide or something, because that I would say I would still trust a human to actually give the proper diagnosis. But you correct me if I am wrong, because somehow I am a bit old-fashioned, and we had those antique microscopes. Now even microscope has evolved so much. You can enhance the image and you can see on the screen and do anything you like. So these are just two queries I have.
So I'll take that first one. I think that's an incredibly important question. I think one of the issues that we see is that there, I think, is a big push to use AI to cut costs and to take, we were saying here before that AI shouldn't replace doctors, but I think that there is the sense, at least in the US, where there are shortages of doctors, where costs are ballooning, that AI could potentially be used as a replacement. And I think there is a need for physicians, for academic medical centers, for people who care about ethics and quality of care to say no, that AI cannot be used as a replacement. And so I think that's one area that's really important, and that we have a potentially critical role to use to say that this is to improve quality of care, to improve the patient-doctor relationship, and not merely to cut costs. The second is that I think we have a responsibility in many ways, the sort of thinking about the unintended harms, both in terms of the carbon footprint of AI, which is enormous, to think about the negative impacts that we have there, to think about the potential for bias in the data sets that we're working with, and to think about the potential for error, as well as the ethical concerns about people uploading their data to the web. So I think in the United States, the Society of General Internal Medicine just published, I think this past week, a set of recommendations of guidelines for the use of AI in medicine. I think that there is an important role for professional societies to come out with guidance and to make sure that that's followed as it's implemented.
Thank you for that question, sir. Actually, it is said that articles published about the comparison of AI with the human observation. So, AI gives an 85% concordance with the pathologist. It's not 100% articles published. And where there is a subjective variation occurs, like between a benign and malignant, in between the borderline category or that moderate category, that inter-observer variability actually this AI minimizes. But what the articles published said that AI is not a substitute for the human pathologist, but it's like a companion which will augment the clinician's expertise. That is the thing. Thank you, sir.
Sir, for the question you asked first, how do you have any checks and breaks for the bad use of AI or the I personally feel, sir, it is very difficult. We cannot control the ChatGPT. We have to pay money. I mean, I don't pay money because we are members of that community, so we don't. But for say Prem to develop, he has to pay a lot of money. It is hourly basis. They charge money to write that article or prepare those slides. But ultimately, coming down, it is good. The worst use of condom is its best use, preventing unwanted pregnancy. So, like that. The ChatGPT or whatever AI is used today, or see, sir, I mean, radiologists are saying they will be without jobs. That will never ever happen. Radiology seats are the highest paid seats, and we keep on increasing seats because there is a demand. And as Professor Bimal said, we can get the preliminary idea, but the final court of appeal is the human brain. So that has to be there. Even though we see we get the diagnosis from the Remedio, that camera is called Remedio, sir. only a very cheap price. We just did it's a couple of lakhs. We get the idea from the Remedio. We always send a pathologist to an ophthalmologist to confirm. So it's called point of care. Patient is sitting in front of you, POC. Point of care, I can give him advice that you don't have any serious eye disease. No, you have a problem. You need a laser therapy, but I will consult my ophthalmologist and call in the evening. So it is always, as you rightly said, sir, human intelligence which will reign supreme, and we should not be the subservient. I mean, it is always said, sir. They said that we should be the boss of the money, then subservient of money. So like that, sir, we should be boss of the AI, then servants of AI. Thank you.
Dr. Venkateshwaran, he spoke about, you spoke about the quantity of data needs to be fed into AI and to
for
make,
learning, yes.
to train
Training
AI.
data set, yes.
Basically, the large learning models, what we need to do.
Yes.
And Dr. Vidyavati was talking about common diseases and uncommon diseases, like how it can do. But whether we like it or not, AI is here to stay, and it is going to go more only. Like I remember only in 2023, September, we had a first introduction to AI. In this place only, we had a conference, and in the workshop it was told. But from then to now, there is a lot of significant change which has happened. So it is going to be there. Do you think that institutions are going to come together to form some kind of a data consortium so that we could kind of get a meaningful inferences from AI? Like if we can come together with as a data consortium, we would be able to get, especially with regard to all these rare diseases, rare diagnostic problems and things like that. See, common ones, yes, training them would be more difficult, but do you see a scope for many institutions to form a data conglomerate or a consortium?
Yeah. So I understand your question that since data is required in huge quantities, if institutions come together, we can generate huge data. So the element that was mentioning that one of the important challenges in AI is cost. What I actually meant cost by the fact is mechanisms to capture data. So even if institutes come together, how are you going to capture data? So that is the idea. So we need granular data in the sense, one of the important for precision medicine, again, what we need is the genomic data. So how much of genomic data do we have? So if you come across the work of Dr. Vinod Skaria on IGIB, and across India they have collected 1,000 of human genome. So to identify, to compare the copy number, the single nucleotide polymorphism, SNPs, to identify genetic diseases, rare genetic diseases. They need a database of 1,000 healthy volunteers. So to get this data for genetic data, so there was a lot of difficulty across the country to find out rare diseases. They need the genomic data across the country. So similarly, when we need patients' vital status, say pulse rate to minute to minute or hourly data, we need implementation of mechanism to capture these data. We talk about electronic health records. Now we talk about electronic health records, but that captures, but say even if we talk about a digital watch, how much data does it captures on the pulse rate, and whether the patient is sweating, whether the patient is, what happens to his pupil size. I'm trying to be, maybe I'm not giving you exact examples, but how much data can be captured minute to minute, hour to hour. Even if the institutes collaborate, what I see the challenge is, there is a need for collaboration. Definitely there is a need for collaboration to gather huge data, but will the institutions participating in the collaboration will be able to provide data and generate data? So that is where I see the challenge. That's where I see the challenge. So, and when it comes to rare diseases, most of these diseases are called, within quotes, orphan diseases. We know orphan drugs. What if I find out such a rare disease. I spend all my life find out the diagnosis rare disease, and where is the market value? Where is the drive to discover and make the breakthrough? So these are kind of orphan diseases, or they don't have any potential for marketing, and where these diseases are seen as an orphan diseases, so they need an initiative from the government side, and people come together, form groups, small special groups, rare diseases. So when it comes to new diseases, there is no such support other than the international rare group, rare disease consortiums. So again, I see to diagnose this, people coming together will happen only when the data is already being captured. Say for example, genomic data is captured, human genome is being captured, and if vitals are being captured in hospitals, automatically they will come together to put the data together. That will happen. As of now, I see this, though there is a need, I don't see this happening in the maybe next 5 years. I don't see this happening in the next 5 years in India at least. Yeah.
Yes, sir, please.
It is about the analogy, madam. Your question is very valid, because they have compared the AI in healthcare, the topic of today, to AI in chess playing. AI in the playing of chess has surpassed human intelligence, and it has been said that you can improve your chess. Vishwanathan can increase even still further his chess talents by playing with the AI. AI, the opponent, and Venki plays with AI. You will become the grandmaster tomorrow. But because the rules of chess are well defined, but madam, the AI application in health needs human intelligence, because the rules, they call it CCDS, the decision making paradigm in the healthcare is too uncertain, madam, and the human biology does not obey the rules that is obeyed in the game of chess. So I don't know how to explain it. You know it already, that the lookalikes, but the different many ways. There are similar diseases. Doctors don't agree. I will diagnose motor neuron disease. Madam will diagnose it's a type of cord compression. They say doctors disagree. The lawyers disagree in the court, but when they go back home, they agree. They go to pub, they drink together, they dine together. Doctors, they disagree every time. Am I correct or not? Doctors differ. Doctors disagree, because there are the rules of the medical science. The great administrators are here, so they disagree. So that's why the rules are not well defined. That is why the AI plus human intelligence is the thing that is called for. Yes.
Where the revolution has occurred is in, say, I can give you the example of whole genome sequencing. It used to take weeks to get analysis of a whole genome. Now it takes few hours. So this is the change which computers and AI and other things have brought. So there are a lot of advances.
Sir, I think it's a wonderful discussion with an eminent panelist, and your perspectives and the knowledge that you have shared on this new area. Still it is a new area, still it is yet to catch up. But I also came across one analogy which says that if you don't know, AI will become like a Microsoft Word within the next few years. And like what Dr. Mahalakshmi said, last year around the same time, that's when we all knew about the ChatGPT. Today, everybody in the room are using ChatGPT. So all these things are catching up very fast. And it was a wonderful panel that we had where you all shared your knowledge. On behalf of Vinayaka Mission Research Foundation, I thank each and every one of you for taking time and participating in the panel discussion. And to sum it up, sir, like what you said, knowledge is having the right answer, whereas the intelligence is about asking the right question. I think there it comes. And I would like to wrap up this session with the famous quote of Albert Einstein, where he tells that education is not about learning of facts, but training the mind to think. I think net, I think all of us agreed that the human intelligence is an important component that need to go along with artificial intelligence for the right usage, and particularly in the field of medicine, it becomes all the more important. In most of the other industry verticals, you may look this as a back-end work because AI can do a lot of things. Whereas when it comes in terms of the patient care, the treating, and the care trajectory, I think the human intelligence is an important component along with the artificial intelligence. Thanks for joining us, sir. Thanks once again. Thank you, one and all.
Thank you to all the panelists for the thought-provoking discussion. Before you return to your seats, may I please request you to come forward to take a group photo? May I request you to come forward onto the stage to take a group photo? Thank you. You may kindly return to your seats. I request Dr. Rakesh Segal, Dean AVM CH, to come forward to felicitate Dr. Ashok Kumar Das, Professor of Eminence and Director Academic, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Puducherry. Thank you, sir. Now I invite Mr. Suresh Samuel, full-time member, Board of Management, VMRF, to come forward to give away a token of appreciation to the panelists. Dr. Eve Rittenberg. Dr. R. Venkateswaran. Dr. Vimal M. Dr. Parthiban Srinivasan. Dr. Vidyavati Satish. I now request the Dean to give the token of appreciation to Mr. Suresh Samuel. Thank you, sir. As we approach the conclusion of this event, I invite Dr. Rajan, Vice Principal Administration, AVMCH, to propose the vote of thanks.
Thank you, ma'am. Good evening to all. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel honored and privileged to get the opportunity to propose a vote of thanks on this wonderful gathering. On behalf of the Arboree Medical College and Hospital, I would like to thank all the honorable panelists and delegates who grace these occasions today with their presence. On this occasion, I would like to remember and express gratitude to our founder, Dr. A. Sanmasundaram sir, and trustee Srimati Annapurni madam. Without their blessings, this event could not have been successful. I convey deep regards and heartfelt thanks to our Honorable Chancellor, Dr. A.S. Ganesan, our Honorable Vice President, Dr. Anuradha Ganeshan, and Mr. J. Suresh Samuel, full-time member, Board of Management, VMR, for the constant support for all such good initiatives. A special thanks to the eminent panelist, Dr. E. Rittenberg, Assistant Professor of Medicine, Harvard Medical School, USA, Dr. Ashok Kumar Das, Professor of Eminent, Director Academic, Mahatma Gandhi Medical College Research Institute, Dr. R. Venkateswaran, Additional Professor of Medicine, JIPMER, Puducherry, Dr. Vimal M., Professor of Pathology, Sri Manakala Vinayaka Medical College and Hospital, Puducherry, and our alumni of AVMs, Dr. Parthipan Srinivasan, Professor and Director of Center for AI in Medicine, Arboree Medical College and Hospital, VMR of Puducherry, Dr. Vidyavati Satish, Professor and HOD, General Medicine, Arboree Medical College and Hospital, VMR of Puducherry, for giving their insight for AI in medicine. I extend my thanks to Mr. J. Suresh Samuel sir, a full-time member, Board of Management, for moderating this program and made this program very interesting and informative. A big applause may be given for each and every panelist who made this event a grand success. A big thanks to Dr. Rakesh Sakal, Dean, and Dr. K. Damodaran, Medical Superintendent, for felicitating our panelist and moderator. Hearty thanks to Dr. Sarman Singh, Director Medical Research and Institutional Collaborations, and Dr. K. Jayasingh, Director Hospital Growth and Outreach, for their invaluable advice to organize this event. My heartfelt thanks to Dean HPE, Dr. V. N. Magalashmi, for welcoming all dignitaries and delegates. I extend my thanks to Dr. Lada, Vice Principal Academic, Dr. Lakshmi Chataya, Vice Principal Students Affairs, Dr. Arunachalam, Deputy Medical Superintendent, and Dr. Aswin Nelson, RMO, for their help and support to organize this day. Thanks to all our head of the Institute of Vinayaka Mission Puducherry campus, Director HR, Mr. Suresh Raman, Deputy Registrar Perumal sir, and Mr. Syed, Head ICT, Ms. Madhumita, Ms. Shagitya, and other officials from Chennai Head Office and AVMC for their gracious presence and support. I would like to thank our beloved heads of the department of their constant help and guidance. I extend my thanks to all the faculties, PhD scholars, students, delegates, and students volunteers, those who have participated today in this day. A big thanks to head of the various sections, informatics cells, publication divisions, space and event management, audio visuals, EDP, transport, photographer. They deserve to be thanked on this day for their services. Without them, this event was not possible. Thank you very much. I thank Hotel Accord for providing the wonderful venue to organize this event. Sincere thanks to media and press for their all-time support. Thanks to Surgicast for providing live streaming of this event through AVM's website. Finally, I thank Almighty for smooth and orderly conduct of this event. I am sorry if I missed out anyone. Thank you all. Thank you so much.
Thank you, Dr. Rajan. May I request everyone to rise as we conclude with the national anthem. Thank you all for your presence. We warmly invite you to join us for high tea. Have a wonderful evening.